Today we will be talking about mobility and safe patient handling from an interdisciplinary team approach. And we're going to hear from a group of bedside clinicians and patient experience testimonies about the importance of early mobility and safe patient handling. Let's hear from Ronnie, our CNA.
My name is Ronnie Turner. I started working as an aide in '92 in a small nursing home in Estes Park, Colorado. From there, I started to do more like a travel aide up and down the Front Range here in Colorado. And after that, I decided, well, yeah, I needed a home. So I applied at a hospital in Northern Colorado, and I've been there now for the last 25 years. My role, I'm a CNA here at the hospital, and my role right now, I do training for the onboarding staff that come in. The training is an hour and a half, typically once a month. And then we also do a phase 2 training for anybody who wants to do the phase 2. And the phase 2 goes deeper. And we have discussions about how to move patients and what equipment that they should be using and stuff like that. Yeah.
I am an internal medicine trained hospitalist. I have been a hospitalist for about going on 8 years after residency. I work with Midtown Inpatient Medicine, which is a hospitalist group in Denver, and we work with SCL hospitals. Inpatient acute medical care is where my passion lies. You work with patients and families at their most vulnerable. You get to see them improve, day by day. Over the years, as I've been doing this, mobility was initially a curiosity. As I became more involved with various hospitalist-driven metrics, it became more of, an active reality, no pun intended. Yeah, in my mind, as a hospitalist, we're at the bedside. We see the patients throughout their continuum of care. So we play an integral part in terms of advocating mobility, bringing it to everyone's attention, but also, it should become our day-to-day workflow.
My name is Jamie Haynes, and I currently teach at Central Michigan University in the Doctor of Physical Therapy program. I've been here at this position for 5 years, but I've been in physical therapy education for almost 15. And my role, I'm an assistant professor, and I'm a board certified neurologic specialist through the American Board of Physical Therapies. So that's pretty much my role. I teach in the neurologic interventions course here at Central. I do a lot of community outreach with people with neurologic conditions, and have begun to integrate, this will be my 5th year integrating safe patient handling content and equipment into our curriculum here.
My name is Chris Guan. I'm retired physical therapy assistant and nursing assistant, and I spent 26 years working at the hospital in various things: cardiac cath, telemetry, x-ray, and before that I was 4 years, I was a Navy Corpsman. I was a medic with the Marine Corps, and I was an EMT. And I worked with the Air Wing with the Marine Corps as an FMS Corpsman and an independent duty tech for a while.
I'm an occupational therapist. I've been an occupational therapist for about 17, almost 18 years now. I've worked in a number of different settings. I've worked in outpatient, I've worked in inpatient rehab, home care. Most of my career though has been in the acute care setting. And within acute care, I started as a floor OT, spent a lot of time in the ICU, critical care, neurointensive care units, as well as I've been in management. So I've had kind of a nice overview.
Sure.
So currently I'm working as a floor OT who serves the ICU, as well as I'm our coordinator for our safe patient handling program at the hospital I work at.
So our outline and objectives for today are to talk about mobility research and literature with some of the newest evidence. We're going to look briefly at mobility screening and assessment tools that aid consistent care across disciplines and care environments. We're going to look through video demonstration about how to build mobility into daily care and think about specifically how we provide safe, dignified mobility to patients of size and also for some specific considerations like COVID-19.
we all know that functional status decline commonly accompanies hospitalization, right? Many people, especially those admitted to the ICU, face functional comorbidities or decline for even a year after hospitalization. Awareness is one of the key things that I see that would improve patient mobility and collaboration amongst the teams. Awareness that some of the common things, poor sleep, poor nutritional intake, it doesn't have to be the patient who has a fracture and can't move, pain, polypharmacy, inappropriate orders, bed rest on a patient that may not need to be on bed rest. These are all factors that play a role in affecting patient mobility, and they can all be mitigated by, hospital-based early mobility programs.
So as Dr. Patel said, immobility can impact all of our body systems. In the ICU, we see ICU-acquired weakness, we see delirium, we see difficulty weaning from ventilator, we see mortality, pressure injuries, long-term cognitive and psychological impairments, as well as as DVT and thrombolytic events. In our med-surg unit, we see incontinence, pneumonia, again, pressure injuries, decreased functional ability and decreased independence. We see more falls, we see confusion, we see patients who cannot discharge home. And this also impacts patients in the post-acute care setting. Prolonged weakness, difficulty resuming social, occupational roles, depression, anxiety, increased use of medication, relationship difficulties, decreased quality of life, and also we see falls in the community and readmission. The only way to prevent immobility syndrome is to mobilize our patients. There is no pharmaceutical intervention. The gold standard of care is the ABCDEF bundle, where A is assessing and managing pain, B is both daily awakening and weaning trials if you're in the ICU, C is a choice of medication, which looks at benzodiazepines versus shorter duration medications that can be reversed for mobility. In the non-ICU environment, choice of medication may be looking at those that create higher fall risk versus those that don't. Assessment of and treatment of delirium, early mobility and exercise, and family involvement. There are many, many studies showing the benefit of early mobility. But there is a very large multi-center trial, over 15,000 patients, that was done through Vanderbilt, and a systematic review of the literature in 2019 that showed early mobility does improve mortality. It improves quality of life. It decreases days on a ventilator. It decreases delirium in our patients. It improves functional level at discharge, decreases length of stay, and it may also improve the number of patients who can be discharged home. So to preserve independence in activities of daily living, patients must actually perform those activities of daily living. Dosage once a day is not enough. We must be getting the patient up frequently throughout the day. 23 hours of not getting up with a 1 hour mobility just is not enough. For non-exercise daily activity, not necessarily exercise, but daily activity, an active change in position relative to gravity is best every 30 to 60 minutes. So let's hear again from Dr. Patel.
But for somebody who lives independently, who does their ADLs themselves, I think we should encourage them to do as much as they can.
And from Dr. Haynes?
So I really see the nursing aspect is extremely important. Just like you said, the research shows, especially in ICU and acute care, that we need to get people up more often, and physical therapists can't be there more often. And so when we work as a team, the therapist is the one that's challenging that patient and is pushing the limits, is in really promoting recovery very specifically in that time frame. But we also need the nurses who are with that patient hours upon hours to reinforce that for us. And so if it's using equipment, if a patient can sit up at the edge of the bed, then they should be sitting up at the edge of the bed to take their medications or eating. If the patient can get into a chair, using the equipment to get into a chair to really follow through with the ADLs that they're going to be needing to do at home. And so, I think that conversation is really important.
And let's hear from Ronnie.
Can you speak to how you build mobility into all the things that you do with your patient in a day?
I would say it's not a once a day task. With our heart patients, we move them 4 times a day. Everybody, because it's helping the circulation, it's helping the breathing, it's helping a whole lot of things. So once a day, when I hear once a day, no, it's not once a day. It's as many times as you can do it.
So what are some of the barriers? Fear. Patients feel it's going to hurt them. Caregivers, they might hurt themselves or their patients. Lack of protocol, standardized decision making. Lack of resources, so equipment, staff, time. Lack of understanding about how quickly to move independently is lost, especially in some of our marginalized patients, and a low prioritization of mobility in daily nursing care. There is a lack of true interdisciplinary teamwork, and there's a lack of standardized mobility terminology and understanding of roles across the teams. So the first thing we want to do is make sure that mobility is safe for our patients. And there are many protocols in the literature. This one is approved by the AACN. And what you'll see is parameters for oxygenation, for cardiac stability, for respiratory stability, for ventilator settings, for vasopressor use. And we want patients to have some neurological stability. So all of the protocols go from a level 1 all the way through level 4, from small movements up to functional mobility. And what you'll see with the protocols is, if the patient is not ready today, what do we need to do to get them ready either the next shift or the next day to be ready to mobilize safely? And you'll see some variation from one protocol to the other in terms of the actual numbers, like for FiO2 or positive end expiratory pressure, the PEEP, on the ventilator. But they're all around the same parameters. What you need to do with your facility is start the conversation and decide on what number you will start to mobilize your patients on, so that everybody is on the same page. This is a great article that came out in 2014, but still as relevant today as it was back then. And it came out from a group of 26 global experts on early mobility. And they came up with a green light, yellow light, red light system for in-bed activities and out-of-bed activities to help clinicians make those decisions where, with a green light, mobility is absolutely low risk and should be proceeded. With yellow light, the benefits of mobility may very well still outweigh the risks, but there may be some increased areas of precaution. With a red light or a stop sign, this does not mean a total contraindication to mobility. It just means that there are significant risks and you need to check with the interdisciplinary team.
I have had family members say, this is too early. And so then we time out, we sit down and we have a conversation with education and involve the patient. And at our higher level patients, we'll say, do you want to get out of bed? And the majority of the time they say yes. They want to get out of bed and want to move. Their back gets sore, their hip gets sore, their shoulders, their neck. So they feel better getting out of bed.
So let's now pivot to why safe patient handling matters as we mobilize the patient.
I know that you have had experience both with caregivers helping you manually and with using safe patient handling equipment to help you get up. Can you speak a little bit to your experience comparing and contrasting what it's like when there are caregivers manually helping you and when they use appropriate safe patient handling equipment to help you?
Well, it's like night and day. For one thing, you can reduce the members of staff in when you have safe equipment handling and you're using it properly, because it's so much more relaxing for the patient to have less staff hovering around. If you've got 4 or 5 people on there, you do feel very uncomfortable because you're going, wow, I'm really big. It tends to be a real negative impact where you can't overspeak this. Is explain how the equipment works and say, this is a sheet. We never used a mobility sheet to turn people. Now we can do that. We can actually turn people every 2 hours. With one person, we never could do that. And it certainly reduces the stress on staff because you have more time with your patients. Mm-hmm. But also it's a confidence builder too, because there's something about when you've got somebody and you can slowly move them with a sheet and turn them, or you can use a lift to get them in an upright position. It's a real confidence builder for the patient to know they can extend themselves a little more and go, well, I can try a little harder because I won't end up on the floor.
What about the comfort and dignity of the movement itself?
Well, you have less hands on the person. So you aren't, when you're lifting somebody, there's going to be a part of it where you're using momentum and not control. You can move at a speed of the machine and it moves very slowly. Plus, if you're using a machine, you can look at the patient a lot more. If you're up close, you don't see the expressions on their face of pain, anxiety, things like that.
Let's talk about the impact of lifting on our caregivers. That nurses, physical occupational therapists are consistently in the top 2 to 3 industries most at risk for a work-related injury. And so the use of safe patient handling equipment is really, really important to keep those who are caring for the patients safe. There are many indirect costs of work-related musculoskeletal disorders that show up beyond the lost time and the medical costs. So we have staff turnover, stress level, lost productivity, replacement staffing, disruption in care, length of stay challenges, patient satisfaction, decreased continuity of care, increased medical errors, increased patient falls, increased pressure injuries, decreased morale, decreased quality of care. We also see absenteeism from unreported injuries. And we also have to recruit and train new staff members when current healthcare workers can no longer do the job at the bedside. So this just shows us that nursing assistants are approximately over twice as likely to get injured as nurses are, and they're more likely than heavy truck drivers, they're more likely than laborers and freight and stock and material movers, they're more likely than construction laborers to get hurt. So we really have to pay attention to how we are moving our patients and making sure that it's safe for everybody.
Early mobility is challenging because it requires the collaborative efforts of busy providers with different training, experience, patient responsibilities. So identifying these barriers has been the key in achieving success in this venue. So one big barrier is the fear that our patients will fall. Safe patient handling equipment is key because it allows our caregivers to maximize our patients' mobility while limiting that risk. So in our mobility pilot at SEL, we use walking slings and mobile lifts for patients with higher fall risk. We also use stand aids to get patients moving sooner. So knowing what safe equipment we have, which will mitigate injury to the patient and staff, is a great educational resource in terms of bringing safe mobility awareness to all.
I think it's helping each other problem solve as a team. Why, looking at the why are there still barriers? How can we fix those? But I can tell you that safe patient handling has changed my practice. From a physical therapy standpoint, from teaching others, and that the immense positive that can come out of getting that very difficult to move patient or that critically ill patient to move again, there's nothing like it. There's nothing like it. And we can do so much more than what we could even 20 years ago. So I just hope people will consider that the joy that this can bring to really make a difference in someone's lives sooner, quicker, and then with less injury to any of us.
I think the equipment gives you so much more, you know, and then with some of these patients without the equipment, I mean, you really can't do much.
We're very fortunate at our hospital to have a wide variety of equipment to use. So in our ICU, we have ceiling lifts, we have dependent transfers, lifts, we have electric sit-to stands, we have manual sit-to stands, and we have the friction reducing slide sheets. So we've got a wide array of tools to use with our patients. I think of maybe some of our more obese or heavier patients that are quite dependent in the ICU traditionally are not moved as much as some of our smaller patients. And so I like to get the ceiling lifts involved for safety for us and for the patient the first couple times that they're out. So we may use the ceiling lift, and even if we're not sure if the patient will need it or not, for safety, we'll put them in the sling and have them sit at the side of the bed. That gives us a safe gauge for what they can do, and that will help transition. With our electric sit-to stands, I like to do ADLs in those. Traditionally, we don't lay in bed to brush our teeth in the morning.
Sure.
So if I can get them sitting at the side of the bed and even standing in one of those lifts, depending on the lines and wires, if I can get them up to the sink or even pull the tray table up and give them an activity to do in standing, if they can tolerate it, we'll do that. And then progress them through to the manual sit-to stands where the patient has to pull themselves up to stand, but they always have that pad there to be able to sit back down on and rest if they need to abruptly. They feel safer, we feel safer, and it helps to progress them through that activity, moving towards ADL that's meaningful.
If there are some watching today who are more inclined to keep their patient in bed because they're worried about harm to the patient by getting up, what would you say about that decision?
I would say it may be a disservice, an unintentional disservice. You may be surprised how easy and safe it is to use this equipment. And if you need resources, to reach out to the appropriate supervisors to receive education on using this equipment, because that may be a disservice to the patient in the long run.
Sometimes I hear people saying that mobility is therapy's job, that it's not really nurses' job to do mobility. What would you say to those people?
I would say it's everybody's job. You know, we cannot wait for therapists to move people. It's part of your job too. We are a team, you know, and unless there's something really, really bad with the patient and you feel as though you need to wait for therapy, then do so. But 99% of the time, we can do it.
And one more word from Dr. Patel.
Having that conversation, integrating that as part of our workflow. It shouldn't be up to the nurse only to have the patient sit at the bedside. I can encourage that. When I examine a patient, I can ask them to sit at the bedside. I can remind them that, you wouldn't eat your meals in bed at home. So why would you do that differently in the hospital?
So we've heard from all of these professionals across disciplines about just how important it is to get the patients up and to use the equipment to do so. So what can we do to improve a common language and terminology across the team members? Although all caregivers are on team patient, each discipline has a slightly different focus. We do have standardized tools that we can use to improve consistency. And although each tool has a unique purpose, each tool also has strengths and limitations. Some of the decisions we need to make throughout the day are: what activity does the patient need help with? How much can they do? How much do they need help? How do I determine how much they need help? What solutions do I have in terms of safe patient handling? And then when we look beyond the mobility screen, the diagnostics: what's wrong with the patient? Why can't they move? Evaluation: how do I decide which treatments will be effective? Is the patient tolerating, responding to the treatment? How well am I preventing complications? So this is assessment, initial and daily. Outcomes: is the patient getting better or worse? And then discharge planning: how do I predict what the patient's going to need when they go home? There are many different tools that we can choose from. For today, we're going to talk a little bit about how we use a mobility screen to build mobility into daily care. So we're going to talk about what the mobility goal is. What activity does a patient need help with? What solutions do we have? And how do we use those to build mobility into daily care? Let's hear from Chris about using a mobility screen.
If doing that screen, if that were part of the practice of every caregiver, every therapist, every nurse, every CNA, do you think that would have impacted your mobility when you were in the acute care hospital, when you were in the nursing home? What difference do you think it would have made, if any?
Absolutely. For one thing, it shows to me that the person that I'm working with, I has confidence in me, but I have confidence in them, because if they're doing a screening, they're actually interested in what are my limitations. They're watching what I'm doing. And you notice, what did that take? 30 seconds? That didn't take any time at all.
That's
And
right.
one of the things, caregivers, I don't have time to do that. And the time it took you to say I didn't have time to do that, you could have done that. I had the broken ankle. I was completely non-weight bearing for 6 months on this ankle. And then I had an injured wrist, but I had no problem transferring to a commode. I would get myself in and out of the bathroom. I would take my own showers because I'm really motivated, and I didn't want to live the rest of my life at 57 years old, 58 in a nursing home. Mobility is not constant, it changes. There's days if the blood clots would be in a certain spot, and I don't know how exactly the physiology of this works, but if they were in a certain spot, I just couldn't breathe. And it had nothing to do with my weight, because once my blood clots, I was on a Grooming regime, I'm not, because I had open heart, but once the blood clots cleared up, I was very motivated. I was motivated when I had the blood clots, and I think one of the things about doing an assessment daily is you can not only gauge the person's mobility, but also, are they motivated to work that day? Are they unable to work?
So there are several types of patient movement. When a patient needs to be moved without actively participating in the movement is the first kind of movement we consider, where it is passive movement. For example, if they're sedated and must be moved to a special diagnostics table, or if they've had multiple trauma and are being moved to an operating table. In these scenarios, we don't want the patient to be moving. The second patient movement is participating in daily activity. It's not necessarily rehabilitation, but it's just getting up for a meal, going to the bathroom, performing daily hygiene. In this case, the goal is to stay active and avoid in-hospital deconditioning as the patient recovers from their illness or injury. And then the third kind of movement is during rehabilitation, when patients are actively trying to recover through a structured exercise and activity program. Our common language includes the kind of help that they're going to need, the kind of equipment that we can use, and both are needed and not mutually exclusive. So we talk about the specific impairments for the patient, we talk about their goals, we talk about how we're going to get them there. For goals, we look at sitting up, standing up, and walking. There are some tools that break these up into more sensitive numbers, but basically, we want all of our patients to reach that highest level of mobility possible. The goal is always to achieve at least baseline that they came into the hospital for, or the highest level that it's appropriate for them given their medical condition. This is a tool that is used to help us choose equipment. It's called a bridge document. And the way we use this tool is we start by looking at what the mobility goal is. Is their goal bed activity level? Is it sitting up? Is it standing up? Is it walking as we move left to right across the bridge document? This gives us the column of equipment options that we are going to be looking at. And then when we look at the screen, how much help do they need? Do they need a powered device, or will a non-powered device be enough? So we look across, supposing the patient's goal is standing today. These are the options that we look at in the standing column. And then we do our screen and we say, okay, they're moderate assistance, and we move down the column to see where the equipment solutions are that we might need. So during the day, we have many opportunities to get the patient up, taking vital signs, giving oral meds. We have meals, which are all opportunities to get the patient up and out of bed into a bedside chair, or minimally getting their heels on the floor for meals. There are many little ditties that I use with patients, which may seem a little bit cheesy, but people remember these. I do not normally pee in bed. Please help me to get up instead. And you can use this. You can make something else up, but do something where you will remember to get those patients up for toileting. Toileting gives you 4 to 8 opportunities a day to mobilize your patient. Activities of daily living are another opportunity to mobilize your patient. My goal is to get back to health. Please help me do things for myself. Repositioning in bed. Again, so often we're quick to do that for the patient. If we can encourage the patient to do that for themselves, or as much of it for themselves as they can. Please help to keep my muscles strong so I can go home where I belong. Again, you may think these are too cheesy to use, so come up with your own. Build in recovery moments throughout the patient's day. Remember what Dr. Haynes said about every time we do something meaningful for the patient, we are releasing dopamine and we are helping them feel better about getting up and moving. So let's look at how we can build mobility in during, let's look at how we can build mobility in during our mobility screening and during our vitals and med passes. During this video, you'll see that the nurse's aide is encouraging the patient to do things for himself, reaching across. Instead of hitting the head of the bed up button for the patient, when you encourage him to do it for himself, he has to reach. He's using his muscles. He's using his heart, his lungs. He's using his brain. So even if he's mobility level 1, if he's totally dependent, he is still doing something active for himself. Now let's look at how he can build mobility into vital signs, even if he can't get up. By bringing the foot plate in this particular bed to meet the patient's feet, he's weight bearing. By inviting him to sit forward or stretch his legs, you're with him anyway during vital signs. By bringing his body away from the bed, he is now working his core muscles. She's having him take his hands off the side rails while she takes his blood pressure. This is going to have him be active in working his core while she is doing his vital signs. With meals, even if the patient is bedbound, we can still put the bed in chair position. So if your beds go into chair position, make sure that you are using that position and bring the head of the bed up and bring their bodies forward away from the head of the bed so that they are working their core even for your most dependent patients. What about putting the patient in a lift or a sling? We can still have them actively participate. You see here that Jim is rolling as the nurse's aide is tucking the sling. If the patient can roll by themselves, let's not roll for them. The same coming back, right? Explain to the patient what we're doing. Have them participate in that activity. You'll see here where even though we're using a lift, the patient can help putting the sling onto the lift. It is always going to be the caregiver's responsibility to make sure that the sling is properly in the lift, but the patient can help with this. This also helps the patient feel like they are part of the process and they're going to be less likely to be fearful. You see him walking his feet around. This also helps strengthen his legs as he's using the sling. Once he's up in the sling, he can also help by pushing the up button, pushing the down button. If the patient is able, this can really empower them to feel like they are part of what is going on. It's also engaging their brain so that they are thinking about what they're doing as they are mobilizing. As they get the patient to the edge of the bed, you'll see they asked him, press that up button until your bottom clears the bed. Okay, Jim, we're over the chair now. I want you to press that down button until you feel the chair under your bottom. So even dependent lifts, we can build mobility in and we can engage the patient. Let's think about how we might engage the patient for bathing. We're using a friction reducing device here to help reduce friction as the patient moves and turns. You'll see the patient is pulling the friction reducing device out from underneath him. This is making him use his muscles. As he's moving to one side, you see him moving himself with the friction reducer and then turning over. The nurse or the nurse's aide may wash the parts of his body that he's not able to wash, but then once they have done that, they're going to give him the cloth to wash any other parts of his body that he can reach. See, even in sitting position with that friction reducer, how he can move himself back and forth, side to side, even as he's sitting. And then when she gives him the cloth, he can then wash the parts of his body that he can reach. When we're grooming, we can do the same thing. Bring the bed up, have the patient look at the mirror, have them sit forward. These are all mobility interventions that we can build in, even in our most dependent patients. Let's look at using a commode. And if you have the option of using a bedpan or a commode or getting that patient up, remember, it is always better, if you can, to get the patient out of bed, to get them into either a bedside commode or onto the toilet. In this video, you see him using his legs, using his feet. In the prior one, we saw a ceiling lift. In this video, we see a mobile floor-based lift that can help us get anywhere, into a bathroom, into a commode that's away from the bed. And you'll see him using a friction reducing device, even with a floor-based lift, to move himself up in bed. We have bed technology that we can use also to help build mobility in for toileting. You'll see him bringing the bed up here to where he can use a urinal in a standing position in lieu of using a bedpan. This is going to help him empty his bladder better. You have to do toileting with your patient anyway, so why not build mobility in and have him standing and weight bearing while he does it? So even in a level 1 patient, have them stand up, have them be active. They can be putting weight through their feet. They can be doing little mini squats. And this is all things you can do when you're with the patient anyway. They're safe, they're not going to fall, and it's going to help them feel better. With repositioning, even if you're using a repositioning sling, you can have them help by pushing through their feet, bending their knees, walking themselves up, walking themselves back. This is going to build mobility in, and they're going to help with that repositioning task. So now let's look at a level 2 patient who can do a little bit more for themselves. You see a mobility screen being done in a seated position. Chris can sit forward in the chair now. He can support himself. Does he have enough strength to stand up? Let's have a look and see. Yup, his legs look strong. Let's try and stand. Oh, that did not work out so well. So let's look at how we might mobilize Chris using safe patient handling equipment. Our goal is going to be walking. Chris is mobility level 2, moderate assistance. We still need to use power to get him up. But he can sit up over the side of a bed by himself. So when it comes to vital signs, it comes to oral med passes, have the patient sit up by themselves in order to do that. If we're going to be doing meals, we can use powered devices to get Chris into the chair. Remember, he cannot get up by himself. So we want to use power to help him get up to the chair. But that doesn't mean he cannot participate. He can help. He can reach the straps up to the lift. Chris can lean forward to make it easier. As the lift comes up, he can help pull himself up to a standing position. Often we will tell patients to try and beat the machine and stand up before it. Once he's at the chair, you can encourage him to reach his hands down as he's being lowered, so that again, this is more of an activity that he is going to be encouraged to participate in. When we go to get him up, again, you'll see him reaching forward, making it easier for the nurses to put the sling onto the lift. He can wipe himself after being on the commode. He can work at the sink or do activities of daily living. And these lifts will go over to the sink. He can wash his own hands. So even in a dependent patient, we can still have them actively participate in their care. We can use a ceiling lift and an ambulation harness to help him stand up. So you see different devices for those that require power to help them stand. Again, how about we include ADLs at the end of the patient's day, at the beginning of their day, have them go to the sink, not just during occupational therapy or physical therapy, but throughout daily nursing care. You'll see as Chris comes back to bed, if he falls, he's safe. He can then continue going back to bed safely for him, safely for the nurses, and you have to do this anyway. So let's lastly look at a level 3 patient who can sit up by themselves. They've got enough strength to stand up. Their leg strength is good. Their sitting balance is good. Their legs are strong. They can clear their bottom. So they're going to try and stand up. They're going to try and hold it for 5 seconds.
Stand for me. All right, 1, 2, 3.
But he's a little wobbly. So he's slightly higher than normal fall risk. We can do this mobility screen in a sitting position as well.
Go ahead and stand up.
So she has him stand,
2,
and we're
3,
asking, can he stand and hold it for 5 seconds? Okay,
Step
next
forward.
step is, can he step forward and back? So before we have the patient walk, we want to know that they can do so safely. In Tim's case, he was not able to, so he's at high risk for falling. We want to use a device to keep him safe. His goal is walking. His mobility screen tells us that he's minimal assistance. He can clear his bottom, but he is still a high risk for falling, so he may still need some assistance. So what kind of devices do we have? We can use a mobility ambulation harness. We can include the patient in putting the harness on, in hooking up buckles, in reaching for straps, in holding straps. The caregiver is still responsible for making sure that the straps are seated properly in the devices, but there's no reason why the patient cannot help with that. And then as he gets up, even though you've got the lift, if the patient can stand on their own, have them stand on their own. But you've now got the harness in case they fall. You've got that safety device. So if they're high fall risk, you do not need to keep them in bed. You'll see him reaching for the chair again so that he doesn't have to rely on the lift. He is still being mobile. We have non-powered stand aids that can help the patient get to and from the bathroom, especially if the patient has urgency. They can pull themselves to stand. But what we want to do is have them put the flaps down behind them, have them do it themselves. So often we are quick to do this for our patients, but have it do themselves builds mobility into daily care. He's got the seat behind him if he loses his balance. We can take this non-powered device around a toilet or a commode so that he can be independent, but he can be safe while he's doing these activities. Again, he's reaching for the commode just like he would without the device, but he is safe both going to and from the bathroom. And then into a chair. We can have him do multiple sit to stands before he sits down. ADLs with an ambulation harness. This is another way of doing it with the floor-based lift or with an ambulation harness and a ceiling lift. There are other devices that are fall arrest devices. This one is called a life glider. It has a little seat under it and it's a walker with a fall arrest mechanism. The patient can walk around the room, they could walk in the hallway, and if they fall, they lose their balance, you'll see that they are safe. So we do not need to limit mobility if a patient is high fall risk. There are many devices across the entire spectrum of debility levels, dependence levels, from ICU all the way to a home care setting, across all disciplines. We can use equipment to build safe mobility in. We know that mobility is extremely important and must be integrated throughout the day. We know that manually lifting and moving patients keeps caregivers consistently in the top 5 industries most at risk for injury. We know there are barriers, but these can be overcome with a team approach, as you heard from all of the professionals today across disciplines, and you heard from the patient himself. Using equipment keeps everybody safe. Safe patient handling mobility is how to build mobility safely into daily care. Using a screening tool helps standardize decision making and keeps everybody safe. There are many ways to build mobility in to daily care that you are doing anyway. We just have to think about it in a different way. Safe patient mobility is best for patients, best for staff, and is excellence in quality care. Thank you. And if there are any questions, we can put them in the chat box and we can answer those questions through email and get back to you with the answers.